second University of Edinburgh Usher Institute webinar on the COVID-19 pandemic. So my name is Aziz Sheikh. I'm Professor of Primary Care and Director of the Usher Institute. It's my privilege to be chairing today's proceedings. So we set up these webinars, they began last week, to try and shed light, international experiences on the evolving pandemic, and the most important consideration that we're trying to identify are actionable insights that we can help, that we hope can help change the course of the pandemic and also mitigate its devastating consequences. So we're doing this as the World Health Organization has today declared that we are approaching close on 1 million cases worldwide. Last week, we had the privilege of hearing from Professor Y.Y. Teo, the Dean of the Saw See Hock School of Public Health from the National University of Singapore, talking about systems level approaches for dealing with the pandemic, lessons from Singapore. It's a real pleasure today to be able to have with us Professor Tongbo Liang to deliver our second webinar. And Professor Liang's presentation will be on the prevention and treatment of COVID-19, practical lessons and insights from experiences in China. Professor Liang, we're very, very grateful for you joining us. We realize that you've just finished surgery, so you're joining us after that, but many, many thanks to you and your team. And we were particularly interested in hearing from Professor Liang because he has been the leader of the COVID-19 treatment team from the first affiliated hospital of Zhejiang. And he's also the editor-in-chief of the handbook of COVID-19 prevention and treatment, which has recently been published by the Jack Ma Foundation. Just before I pass over to Professor Liang, just a few words of thanks. So Dr. Y has been very, very helpful in helping us set up this and running various tests in advance. So thank you so much to Dr. Y for your support. We have Crystal Lai from the University of Edinburgh, who's a native Mandarin speaker and will be available to help if needed. So thank you, Crystal, for joining. And also thank you from the Usher Institute and to Professor Linda Bald, Susan Buckingham, and our communications team for all the hard work that's gone on into preparing for this webinar. Professor Liang, we are very, very grateful and we really look forward to your webinar. Thank you so much.
Okay. Dear professors, good afternoon. In China, this is 4 o'clock. Yeah, it's all happy and very pleasure to meet each other from the telemedicine. I'm Dr. Liang from the first affiliate hospital of Zhejiang University. Today, my colleagues, Professor Chen and Professor Zheng and etc. Involved this meeting. I will introduce our primary experience during the period of anti-COVID-19 today. Even though my oral English is not so good, but my colleagues will translate maybe sometimes if it's difficult to understand or my misunderstanding, misleading. Okay, I will go on. Yeah, my oral presentation, the title is Prevention and Treatment of the COVID-19, Practical Lesson and Insight from China, especially from Zhejiang province. Okay, I will give the brief introduction of this disease. As you everyone know, this disease increases largely and quickly in the world, globally, I mean, especially in the Europe and America. Now the total number is more than 800,000 of cases, and deaths is more than 40,000. So the chance of the increase grow up quickly. So it's very terrible, very, very challenging to human being, to us. And in China, as you know, in Wuhan and the Hubei province, it also has many, many cases, many, many infected and patients. in Zhejiang province. Zhejiang province total is just similar, the size is just similar as Italy, and the total number infected is more than one. I remember it's 1,200 cases. Our hospital is medical center and to treatment of the critical ill and severe patient for the Zhejiang province. Is current point is one center, only one center for treatment of this kind of disease for Zhejiang province people. Up to now, we already treatment the 105 cases a patient. Also, we treatment more than 200 suspect patients during the two months. The mortality is 0, and the staff, the doctors and the nurses involving in the activity of antivirus, the cross infection is 0, and we didn't miss anyone, any people. The suspect the patient, and during the 2 months. So I will focus on our hospital work strategy. The hospital management of the anti-COVID-19, and another is our group, or MDT, the diagnosis and treatment experience of this disease. So the hospital strategy for managing this disease, including the different paths. I will focus on the fever clinic. As you know, the fever clinic is very important area to diagnose and spread this kind of patient and or suspect people spread from another people. So in our hospital, the fever clinic is only every patient if have fever, he must go to the fever clinic first, and not the emergency area. This is very important for this period, because so many people from the Wuhan, from another side of the China, we didn't know if the patient have epidemiology history and the travel. So if a patient have fever, you must that patient go to the fever clinical area. So the fever clinical area, we have the layout, the zone arrangement, and the patient management of the rules. So if patient have fever, you must ask the patient where the patient from. Didn't he or he go to the for example, Wuhan and another epidemic area before the 2 weeks? And how about the symptoms of this patient? If patient have the fever and the cough and etc., we will get the chest X-ray or CT scan. Sometimes if suspect people be infected, we will give RNA, where's the RNA detection? During the waiting time, during the RNA result, the result is pending. The patient, outpatient cannot go another place. He must waiting directed, fixed the area to waiting his result. If the RNA is negative, maybe we included the patient, the outpatient be infected of the virus. And the patient must wear a mask if they go to the fever clinic to see doctors. And the staff working in the clinical area must wear the protection shield and the mask, and 95 mask, and have the cap, etc. In the handbook our group edit, we already demonstration in the figures how to protection our staff, how to spread of this kind of patient to the general patient, how to spread the clinical fever fever clinical to another general clinic. Optimizing of the visit process, this is the flow chart. This picture shows the flow chart. And the patient has fever, we give the fever outpatient service. And step by step, you know, if the recorded of the infected, maybe that patient go to another clinic to see doctors. Usually we ask the outpatient in the fever clinic to write down the questionnaire. The contents just is including the travel history and the symptoms and etc. So very important. It's very important to give the doctor the clue. Does this outpatient be infected or not? And for the already confirmed, I mean the patient, we collect the patient together in the one new campus. I mean the we have the new campus in Zhejiang campus of the hospital. As the picture show, we have the different buildings. The different buildings have the different function. For example, building 3, we collect the mild and moderate patient. The building 5, which is the ICU ward, we collect the treatment of the severe and critical ill patient. And the building 2 for our staff, the staff risk area. So I will make a focus. I will focus on. I will insist. I will point out is the staff. I mean the doctor and the nurse cannot go home after to see the doctors, see the patient. I mean to take careful of the patients, patients. As I know, in some countries, the doctors and the nurse will go to the after duty off or go home. So it's a high risk because you didn't know the doctor or staff or medical staff be infected, yes or not, before the sometimes manufacturing already. So we all use the building 2 to let our staff rest. At least the finish of the antivirus convention is okay. And the building 6 is your management of the hospital. How about the diagnosis and the treatment of this disease? So as you know, the epidemiological history is very important to diagnose this disease. If the people within 2 weeks before onset of the disease, the patient travel or residence history in the high-risk area, or have the together or work together, or the already diagnosis of the people. That is very important information and news for doctors. And another clinical manifestation. So usually the patient has a fever, and this fever not high, but it's mild. Usually about the 37.5 degrees centigrade. And another is coffee. Usually the patient is dry coffee. I mean no symptomatic in the early phase. White blood cell is shows the lymphocyte count decrease, and the white blood cell within the normal range or decrease. So you should give this kind of patient of the CT scan. Usually we give the CT scan, not the general X-ray. We have the one machine, I mean the CT machine, only for this kind of patient, the diagnosis for the chest scan. Now this machine now to the service for another patient, another outpatient. I mean, spread of this subject patient to general patient. This is very important to prevent the cross infection. And about the diagnosis, as you know, the golden standard diagnosis is you check the result shows the RNA is positive of the virus. We use a PCR method. Today, my colleague, Dr. Chen Yu, is director of lab do the many methods of the to detect of the virus RNA level. Suspect cases with a characteristic manifestation in the CT scan can be confirmed case, even though the RNA is negative. Usually, we also find some people, the result RNA is negative, not one time, sometimes many times. We find one patient, the 5 times is negative, but the CT scan shows very typical of the COVID-19. So we didn't let this patient go out or at discharge, I mean. In the 6 times, we find the RNA is positive. So it's very important, especially in the epidemic area, very high risk epidemic area. If the people have the symptoms and the CT scan show the typical feature of the COVID-19, even though the RNA is negative, you cannot exclude the patient be infected already. And of course, history is very important. The clinical manifestation I just mentioned, including coffee, fever, fatigue, and muscular pain. And the respiratory symptoms may be mild dry cough without expectoration, may the deterioration or chest distress and shortage of breath. This is usually is the moderate or severe state. And sometimes some people have no symptom, no symptoms. We find one patient already be infected, and she didn't know where he be infected. And we look for, and I mean the exploration history and the travel history. We find one people already worked together or had a meeting together, but that patient had no symptoms, but RNA is positive. So this kind of people is symptomatic. And the laboratory feature usually is a white blood cell is within the normal range. This is the typical of the CT scan of the chest, including moderator, severe, and critical. For the moderator, usually unilateral or bilateral lung inflammation. This is usually in the margin of the lung. And for severe, the inflammation becomes bad, and the function volume of the lung decreased. For the severe, in the late stage, critical ill patient, as you know, the slide shows the bilateral inflammation very severe, and the bilateral lung become the white. About the treatment, we usually, as you know, in the world up to now, have no sensitive of the drugs to this kind of disease, even including the antivirus treatment. I know in the US, the receiver maybe is sensitive or special to kill the virus, but up to now we have no very stronger evidence. In our group, we usually use the lipinavir and the ritonavir. This is the compound drugs for treatment for HIV, as you know. And usually plus the Abidur. Abidur is a drug for anti-frozen, right? Usually we give the patient 2 kind of drugs. Another choice is some of the favipiravir and etc. Another kind of the antivirus drugs. Usually it's RNase inhibitor or some protein inhibitor drugs. About the chloroquine phosphate, in our group we didn't use anything before. we had no experience about this kind of drugs effective. In China, some medical center recommendation these drugs to treatment of this virus. We didn't use any before. Interferon alpha, we usually for everyone patient for the inhaled in the local drugs usage, inhaled nebulization, and sometimes if we give the patient a tracheoscopy, we give the drugs in the locally, I mean in the lung. And the course of the antivirus usually is about 2 weeks, sometimes with more than 2 weeks for the critical and the severe patient. Depends on the RNA and of the virus change. If the RNA becomes negative, we will stop the antivirus. And this is one method. Another is we will mention and folks is the steroid usage. Steroid usage, as you know, is a very controversial and have the argument between our physician or between among our different centers. In our group, we feel use the steroid early, maybe benefit our patient recovery. The indication for the steroid usage is patient have fever or some the CT scan show the inflammation. We felt if we give the mild and moderate patient of steroid, some patient will stop the mild or moderate stage, not change to the critical ill. And if the severe or the critical ill patient use stage, the oxygen state will become better, and the lung CT scan show that maybe become better. But I must mention is about the dose. The dose you cannot give so large dose. We usually get 1 milligram per day per kilogram. And if the patient CT scan or the manifestation become better, we usually tapering continuously, gradually. Usually we give the 2 weeks, sometimes about 1 month. Sometimes maybe some patient will have the GI bleeding, but we didn't know yes or not is the side effect of steroid. As you know, the stress is very severe, maybe from another reasons. And the third measure, the important measures is the therapy of the hypoxemia. Oxygen supplication is very important. It depends on the patient situation. Usually, we give if the patient the oxygen index, right, less than 300 millimercury. Yeah, mercury. We usually give the oxygen inhale. The treatment goal of the oxygen therapy is to maintain oxygen saturation more than 33%, 93% and 96% without the chronic primary disease. And if a patient combine the chronic disease, we will let the saturation around 19%, right? And the high flow nozzle cannulation for oxygen therapy, we usually also use this method. Such the different criteria of the oxygen therapy, different patient. This slide shows if saturation oxygen is less than 93% and the oxygen index less than 300, we give the high flow nozzle cannulation. Sometimes we'll give the intubation. And before I will introduce the tracheal intubation, I will introduce some of the permanent position ventilation. This is the position drainage. As you know, some of the older patient, other patient in the bed for a long time, and some of the sputum cannot be extruded. I mean, you must get the upside down and permanent position ventilation to help the lung recovery to help to prevent of the treasure block by spreading. It's a very important measure. For the mechanical ventilation, I just mentioned before. If the no injury ventilation had effective, you should consider mechanical ventilation. This slide shows the mechanical ventilation criteria. So the very important guideline is the patient feel the oxygen, hyperoxygen, and the rhythm of the breathing increasingly, even though you gave the high flow nozzle in high oxygen, no effective. And the CT scan shows the inflammation become better and better, and the patient fever, and you should consideration on mechanical ventilation. Another treatment of hyperoxemia is the ECMO. In the world up to now, ECMO is used not so common, even in Wuhan. Some doctors believe the ECMO, if the patient receives ECMO or mechanical ventilation, the mortality will increase. But as you know, if this kind of patient have the shortage, have the breathing, lung function failed, we must give support therapy. I mean, the ECMO support therapy is very important. In our group, we gave the 12 patients receive the ECMO, combined, sometimes the combined treasure intubation and the treasure storming. So the different kind of ECMO, including surgical ECMO, replacement ECMO, early awake ECMO. So because of the time is limited, I didn't introduce the detail about this measure. And about the ECMO mode, according to the patient, the lung function and the heart function. If the heart function is good, maybe VV mode is enough. If the cardiac problem, maybe VAV, or patient, if patient have the shock, combined shock, maybe VAV model is necessary. How about the stopped when and stopped the ECMO treatment? Even on the patient the saturation, I mean the oxygen saturation, and the CT scan show CT scan result, and where's RNA PCR result, etc. So you should discuss with your group, with your MDT group. Does this patient well, winning, or I mean the stop ECMO, or how more ECMO we will give? Application of the bronchoscopy is also another method of the treatment of the lung and the problems. They have the benefit. You can detect, you can report and find of some disease. You can suction of the sputum from the bronchoscopy. You can give the drugs locally, and you can let the bleeding and the treatment of bleeding complication. Use the bronchoscopy. You can compare the before and the after the bronchoscopy treatment. You can give the evaluation of the prognosis of this patient by the bronchoscopy. You can give the irrigation of the lung and take some samples to give the bacterial culture, fungus culture, and the various RNA tests. Other therapy including liver facial support system. As you know, some drugs have the side effect of impairment of liver function. We found about 20 to 30% have the injury of the liver enzyme. Some patients have the TB level increase after use the antivirus, especially for the rifampicin combined of the epidural. So usually we will stop this kind of drugs, and sometimes we will give the artificial liver support system. Another effect of the ALSS, you can decrease the cytokine level. We gave the most some patient of the CRRT because of the renal function impairment and the oliguria, and we also balance of the intestinal microscopic and the nutrition support. As you know, some of the critical ill patients will have the long history of the disease. So the nutrition is another issue, very important. Another important issue you must focus, take care of. We usually give the nutrition tube in placement in the jejunum as a gastroscopy, not from the gastric, but the nutrition sub infusion into the small bowel. And plasma therapy is also an important method. If you can get from the recovered patient, this kind of patient, the plasma have the antibody. We gave about the 20,000 milliliter totally give the different patient. And the treatment in China, we have the traditional Chinese medicine. This kind of drugs have the effect of antivirus, including maybe including COVID-19, including some another kind of the virus. Usually, sometimes if I give some frozen, sometimes I usually take some Chinese traditional medicine. And the nurse group is very also important the team. As I just mentioned, the CRRT, artificial liver system, ECMO, is this kind of the technique is needed of the professional nurse team. So we established a group of the nurse who care of the CRRT, ECMO, ALSS, and some the lung recovery and resuscitation, etc. And usually we will give the rotation every 4 hours for the nurse, for the physician, because as you know, the staff worked in the ICU is very tough work and is very challenging work. Another life support is very important, the MDT. In our group, in our 105 cases, we already done the double lung transplantation for 2 cases. This is the first 2 cases in the world. We just published our paper in the annual surgery. One is more than 60 years old, one is more than 70 years old. Because in the late phase, the bilateral lung of the 2 patients become white, and with the ECMO for at least 3 weeks, and no phenomenal change better. So we gave the ECMO 11 patients, tracheal intubation in the 60 patients, and the tracheotomy in 11 patients, and the bronchoscopy in 12 patients. A total is more than 100 times, and the gastrointestinal in the endoscopy in 14 cases, and the total times is about 40 times. Artificial liver support system also gave the 71 times, and the radical surgery for the sigmoid cancer removed in 1 patient, CRRT more than 300 cases times, and cesarean in 1 woman, and the temporary cardiac pacemaker implantation, one lady, one lady, and hemostasis with embolization in 5 times in 4 cases, and recovery plasma treatment more than 20,000, 21,000, 21,000. And the vasoligation because the local bleeding, as you know, in ECMO and the CRRT, some the femoral artery injury, some the femoral vein injury. So we closed or gave the stand placement, and we gave the PCI one patient PCI because of the heart rate. Under the discharge criteria, including the patient if have no fever at least 2 days, and the oxygen are unnecessary, and the RNA of the virus is negative at least 2 times. The interval time is at least 24 hours, and you can compare the CT scan before and after. So the CT scan become better, and sometimes the lesion disappear already. You can let the patient discharge. But if patient go to the home, he must stay in the home at least 2 weeks. And 1 week later, you will see doctor again. We will give the RNA test during the first time of the interview. The doctors we give the CT scan repeated. Sometimes the patient will become the positive, and sometimes the CT scan become the bad, even though the patient is discharged. We follow up is very important. This is the typical. I will show the typical 4 typical of the cases. This is the gentleman, 19 years old. He was hospitalization with the chief complaint, fever and coughing, and the shortage of the breath for 3 days. So we give the mechanical ventilation and the tracheotomy, right? Yeah, during his treatment period, and the patient recovered well, and stayed in the home more than 1 month, and stayed in the home 39 days, right? So usually for the elderly patient, the mortality increase. So this is the one patient of the 19 years old. We have another one is 96 years old, already recovered smoothly, even though we give the mechanical ventilation, so recovery. And the case 2, the second case is a female, 65 years old, complained of cough for the about 2 weeks, with fever for 3 days and shortage of the breath for 10 days, for 2 days. She was transferred to our hospital, the local hospital, with mechanical ventilation. As you know, then the day 15, day 22, day 27, and the day 130, the change of the lung, bilateral lung, changed better and better. So we have no any choice except lung transplantation. So after MDT, we decided to give this patient lung transplantation, even though the patient is already more than 60 years old. So the last one picture shows day 2 after transplantation. So we can see the lung become normal. The second picture shows the bilateral lung is become white. This patient received the tracheotomy, mechanical ventilation, and ECMO. Now the patient will discharge within 1 week. This is the case 3. Is mild and 62 years old, has a fever, cough, and admission. So on the day 4, day 30, and the day 50, you can see the CT scan, the lung situation. But the patient recovers smoothly, even though we believe the patient has no hope to recovery. But we insisted on, we gave them multiple modalities treatment, including the ECMO, I just mentioned the steroid, bacterial infection and the function infection, give the tracheoscopy to suction of the sputum. The patient recovery from his lung on the day 45 and on the day 60, the CT scan showed the lung become better and better. We hope the patient will discharge within 2 weeks. The ECMO will stop. We will stop the mechanical ventilation later. This is a third patient, and the fourth patient is a young patient from the Wuhan, and also, no, this is the female. Is the patient received the cesarean delivery, even though he be infected by virus. The baby is well and no infected by the virus. We gave the detection of the including bloodstream, sputum, and the umbilical blood sample and the stool sample. Every sample from the baby is negative. So the mother and the baby already discharged for a long time and he well in his home. So in the last, I will show some videos. So the first video is 96 years old lady and recovered well. You can see in my left hand, and the middle video is we do our group do the lung transplantation. So the patient transferred to the OT. This picture show our group do the lung transplantation. We have the protection shield, prevent our staff be infected during surgery. And the last one is also I just mentioned the lady delivered his baby. We also give the cesarean. Yeah, we're very, very happy in our group because the mother and the baby is safe, is safety. So at the last, I will introduce the handbook. Maybe some professors and the doctors know this handbook. Is our group edited last 2 weeks ago. Even though some of the concerns or experience not have so strong evidence, but this is the summary of our hospital summary of the work summary and our primary experience. I hope in future the colleagues and the physician give us some suggestion or exchange your very important knowledge, very precious knowledge skills to antivirus. Thank you very much.
So Professor Liang, thank you so much for an absolutely fascinating presentation. And thank you to you and your colleagues for the outstanding work that you've done, not only in your own hospital, but in producing this very valuable book. What we will do, colleagues, is with the slide deck that we circulate at the end of this presentation, we'll also circulate a link to the manual, which is available free of charge. In a number of languages now. So Professor Liang, we had some questions that came in advance of your presentation. So maybe we'll start with those and then I'll try and take some of the questions that those listening in have submitted. So the first question was, have there been any cases of transmission in the hospital from patients who are COVID-19 positive, either to other patients or to members of your healthcare staff?
Which one? I forget this data during my presentation. We have the 3 0. 1 0 is the mortality 0. Another 0 is our staff being infected ratio is 0, and another 0 is the patient that no. stuff, the diagnosis or misdiagnosis. I mean, the false positive and false negative is 0.
Okay, thank you, Professor Liang, for that. So you mentioned the follow-up that you're doing of patients who are discharged from your facility, and it seems to be very comprehensive follow-up. And so there's a question from Ting Shi, and it's, have any of these patients who've been discharged had recurrences? Have they tested positive again on the PCR?
Yeah. In our group, we have only one case become positive after discharge. But in other medical center, I know about 10% positive change after the discharge, patient discharge. But even though the patient become the positive from the negative to positive after discharge, the patient condition is well.
Thank you. So the next question, Professor Liang, is in the UK, we're hearing a lot of reports of patients reporting loss of smell or loss of taste as symptoms of COVID-19. Are you seeing any of this in your practice in China?
没有嗅觉味觉，没有异常，没有。
Yeah, the Professor Sheng said no, because the Professor Sheng is an infection disease of the department.
Okay, so the question was, any loss in the patients who are turning positive, any reports of loss of smell or taste?
Yeah, some patients maybe lose the appetite, but maybe appetite, right? But maybe by side effect of drugs, not the very infection. Because the patient received so many drugs, yeah, we cannot clearly know what is the real reason of the patient lost the test, right?
Okay, thank you. So what we'll do is, because there's a lot of questions, so what we will do is, Professor Liang, is we'll pass these questions to you, and maybe if you and your colleagues would have a chance to go through them, then we can communicate the responses back to the participants, because you have this unique experience. But I'll try and take a couple more questions. And so there's a question about with all the cases coming in, what is happening to other services, routine services, patients with diabetes, myocardial infarct, stroke, etc.? Is care proceeding as normal for other patients?
You mean the patient combined with another disease, right?
No, so
okay. And the general work of the
yes, the general work.
Yeah, general work. I just show the photo and the picture of the chemist. We spread of the general patient away to the general patient and the COVID-19 patient. The spread, the different area, different building, depends on your hospital situation. I recommendation, this kind of patient must spread of the general patient. Depends. In our hospital, we have another new complex for early treatment of the COVID-19 disease.
Okay, so I mean, your approach is then complete separation of COVID-19, and I mean, other patients are being dealt elsewhere in the system. Okay, that's very helpful to understand.
Yeah.
So then there's a question around the number of CT changes. How quickly are these appearing in your patients, the CT changes?
我们一般都是48小时到72小时重新拍一下。那么有的进展很快的病人，他临床也有表现，比如说高热， 阳饱和度明显的下
CT 最
降。
快的可以
对
什么时间表现？
CT 最快的表现一般大概3天、3、5天。
Dr. Sheng just said that usually the CT change every 3 days quickly. Yeah, 3 days. So if you have the ability to give the patient the CT scan, you should give the CT scan every 3 days to 5 days. But as you know, I just mentioned the patient received the ECMO on the CRRT. So many machines, it's very difficult to move the people to the CT room.
Thank you. So, I mean, it's a very frequent CTs, and these changes are, occurring pretty rapidly. So, my last couple of questions to Liang is that there's a question around: have any of your patients been included in randomized controlled trials? So, do you have randomized controlled trials going on?
Yes, we want to do some clinical trial, but as you know, the situation is very severe. From the ethical committee, we must put the patient benefit first. So
Yes.
the clinical trial is very difficult to do underground. I know some people, some team just underground clinical trial use a receiver in China. I do not know the real result, the final result up to now. Usually, you cannot continuously real clinical trial because you didn't know which is the sensitive, which is the sensitive of the method or drugs. So your patient that suddenly changed, maybe you will change the treatment method. It's not cannot underground the clinical trial first, but the patient safety is first.
Okay, and the last question, Professor Liang, is that you have a very large and important data set, and there's a question about whether this can be made available to the research community. So if colleagues wanted to access your data set, is that available?
Yes, we can share our data bilateral, the module,
Good.
We can
Okay.
share the data together in the future.
Thank you. So, Professor Liang, thank you so much again, and it's wonderful to see your team there with you, and thank you so much for all the work that you're doing. We really appreciate that. It's been a wonderful presentation, and what we'll do is we'll share everything with colleagues and also send the questions to you to see if you have any other responses. But thank you again.
Yeah, you're welcome.
And Susan, if you could just put up the slide for the forthcoming seminars, please.
Yes.
Yeah. Susan?
So Dr. Wei, if you stop sharing your screen now, great.
Okay, wait a minute.
Good. Okay, so colleagues, just to alert you to 2 forthcoming events, which we hope you put the dates in your diary for. The next one is Stephen Hoffman on Thursday, the 9th of April, talking about experiences from Canada. And then our 4th webinar will be on experiences from Hong Kong on the 17th of April. Thank you everybody for joining. Thank you again to Dr. Liang and his wonderful team. We'll share everything with you in due course, and do please cascade on to colleagues. This is all freely distributable. So we'll end the webinar here. Thank you everybody for joining. Goodbye.